Hello everyone. Okay, so we are starting the Osce preparation of pediatric subject. We will discuss some common and clinical cases and the instruments and whatever which is important for the Osce of pediatrics. We will start from the first clinical case, that is thalassemia. What is thalassemia and what is the clinical presentation of thalassemia? In thalassemia, the patient will be pallor. This will be the clinical appearance. Jaundice will be there. Bossing of the skull or frontal bossing. Maxillary overgrowth is present. Depressed nasal bridge. Massive hepatosplenomegaly. Iron overload may lead to hepatic fibrosis, cirrhosis, and darkening of the skin. This is the darkening of the skin. This is bossing of the head. This is maxillary overgrowth, depressed nasal bridge. So all these are the clinical appearance of thalassemia. Okay, autosomal recessive. What will be the investigations done for thalassemia? CBC. In CBC, HB will be low. Reticulocytes count is increased from 5 to 10%. Peripheral smell will be microcytic hypochromic anemia. Target cell. Serum iron is elevated and total iron binding capacity is normal. Serum transferrin saturation, HB electrophoresis, and bilirubin elevated or normal. These will be the investigations found in the case of thalassemia. Now, what are the types of thalassemia? It is thalassemia minor and thalassemia major. In thalassemia minor, HbA decrease, elevated HbA2 up to 10%, elevated HbF up to 7%, while normal is equal to less than 2%. In thalassemia major, absent HbA, elevated HbA2 greater than 3% and HbF greater than 90%. How to manage the case of thalassemia? Blood transfusion is done. Desforexamine is given. Splenectomy is done in case of hepatosplenomegaly, and bone marrow transplantation is done at the end stage. Okay, what is VSD? Ventriculoseptal defect. It is the most common congenital heart disease. Left to right shunt is present in VSD. What will be the clinical appearance? Cyanosis will be there, poor feeding, heart failure, sweating, poor weight gain, tachypnea, pansystolic murmur at left lower sternal border, holosystolic, hepatomegaly, Eisenmenger syndrome. What is Eisenmenger syndrome? When left untreated, then shunt change from left to right shunt into right to left shunt. What investigations are done in the case of VSD? Chest X-ray is done for large heart and pulmonary edema, ECG for left ventricular hypertrophy, and echo. What are the treatment options? Surgery in first year for ventricular septal defect, treat heart failure, and prevent pulmonary vascular disease. What are the complications? Heart failure, endocarditis, and pulmonary hypertension are the complications of VSD. So, how the patient of VSD will appear? There will be cyanosis, poor feeding, heart failure, sweating, poor weight gain, tachypnea, pansystolic murmur, hepatomegaly, and Eisenmenger syndrome. To investigate the VSD, we will do chest X-ray, ECG, and echo. What is the treatment option? In first year of life, surgery is done. If heart failure is there, we will treat it and prevent pulmonary vascular diseases. What complications can occur? Heart failure can occur, endocarditis can occur, and pulmonary hypertension can occur in the case of VSD. TOF, tetralogy of Fallot. It is the most common cyanotic heart disease composed of pulmonary stenosis, right ventricular hypertrophy, ventricular septal defect, and overriding of aorta, right to left shunt. These are the common cyanotic heart diseases. Clinical presentation of the tetralogy of Fallot will be there will be central cyanosis, there will be clubbing if not treated. Dyspnea on exertion will be present. Harsh systolic murmur is present in tetralogy of Fallot. Single loud S2 is present and growth retardation will be there. What investigations are done to investigate tetralogy of Fallot? Chest X-ray is done. Boot-shaped heart will be there. ECG is done. Right axis deviation and right ventricular hypertrophy will be present. Echo is a gold standard investigation in the case of tetralogy of Fallot. Okay, what are the complications? Brain abscess, cerebral thrombosis, bacterial endocarditis, and heart failure can occur in the tetralogy of Fallot. What are the treatment options? Prostaglandin E1 infusion if cyanotic at birth to prevent ductal closure. Augmented pulmonary blood flow with palliative systemic to pulmonary shunt. Surgery is done in the end case. These are the diagrams. This is tetralogy of Fowler. This is overriding aorta, right ventricular outflow tract obstruction, ventricular septal defect, right ventricular hypertrophy. Moving toward next, we are having PTA, persistent duct connecting aorta and pulmonary artery. Persistent ductus arteriosus or patent ductus arteriosus. Connection just distal to left subclavian artery. Blood shunted from high pressure aorta to pulmonary artery. Increased pulmonary blood flow. What are the association? Congenital rubella syndrome and premature. This occur in the patent ductus arteriosus. What are the clinical appearances of the patient of PTA? There will be left ventricular hypertrophy, systolic thrill on upper left sternal border is present, and machinery murmur can be heard. What are the investigations which will diagnose the case? Chest X-ray, ECG, and echo. What complications can develop? Recurrent heart failure, recurrent pulmonary infection, infective endocarditis, and reversal of shunt can develop in the case of patent ductus arteriosus. What are the treatment options? Preterm intravenous indomethacin is given and surgery is done. For other cardiovascular diseases that are formed by birth, that is PTA, patent ductus arteriosus, tetralogy of Fowler, and VSD, surgery is the best treatment. Okay. EEG, it is done for epilepsy, and these are the types. This is burst suppression, this is epileptiform activity, this is diffuse slowing, this is normal EEG. This is myoclonic seizures. Okay. Facial palsy. Facial nerve palsy, what are the causes? Idiopathic infections may cause herpes simplex, Guillain-Barré syndrome, otitis externa media, mastoiditis, and intracranial neoplasms. These are the causes that can lead to facial palsy. What will be the clinical presentation of facial palsy? There will be absent nasolabial folds, asymmetric eye, deviation of mouth, and inability to close eye. What are the treatment options for facial palsy? Care of eye, feeding care, and physiotherapy. What complications can develop? Exposure keratitis and corneal ulcer can develop in case of facial palsy. These are the pictures that show facial palsy. This is Bell's palsy, blink reflex abnormal, earache, lacrimation deficient access, loss of taste, sudden onset, palsy of nerve muscles. All symptoms are unilateral in one side of face. Okay, the next case we are having is Down syndrome. All the cases we are discussing in this PDF are very important and common clinical cases. So we are going through a short summary of these cases. Most common autosomal disorder, non-disjunction. What are the causes? Failure of chromosomes to disjoin normally occur during gametogenesis when extra chromosome 21 chromosomal abnormality trisomy occur. Extra chromosome is added and it causes some features which is known as Down syndrome. What are the clinical appearances of the patient? Characteristic facial appearance, flat occiput, microcephaly, upward slanting eyes, low set ears, single palmar crease, one transverse crease, small maxilla and palate, broad short neck, mentally retarded, delay milestones, fine silky hairs, depressed nasal bridge, wide gap between first and second toe. These are all the characteristic facial appearance of the Down syndrome patient. You can see flat occiput, microcephaly, upward slanting eyes, low set ears, single palmar crease, small maxilla and palate, broad short neck, mentally retarded, delay milestones, fine silky hairs, depressed nasal bridge, wide gap between first and second toe. Now, how to investigate? We will do karyotyping, we will check for the chromosomes and echo. How to manage the Down syndrome patient? Genetic counseling of parents and educate them. General health support, for example, good nutrition. Manage complications, rehabilitation as any case of mental retardation. What complications a Down syndrome patient can develop? Immune deficient, recurrent infections can occur, mental retardation, congenital heart disease, renal anomaly, diabetes mellitus, and duodenal atresia. These are the common complications that occur in the Down syndrome patient. Now, what is infusion chamber and what are its uses? Uses of infusion chamber: administered calculated and monitored fluids and electrolytes, administer drugs, administer blood, slow IV administration of precise volume over a given time, limit the risk of hypovolemia. Now, what are the indications? In what cases we use infusion chamber? In intravenous aminophylline, intravenous diazepam, calcium gluconate. For these purposes, infusion chamber is used. How to give fluid 250 ml in 1 hour? 250 ml per 60 minutes is equal to 4.01 ml per minute. The fluid amount is divided by 60 per hour. That is, if it is 1500 ml, let's suppose, then divide it by 60 minutes, and whatever the result is, that amount of fluid is infused in 1 hour. Okay, this is the infusion chamber. What is LP procedure picture and LP needle? Position, left lateral position. This is the left lateral position of the patient. Where is the infusion or LP puncture occur? At the L3 and L4 level. Lumbar region, L4 and L3 and L4. What are the indications of LP puncture? It is done for therapeutic purposes as well as diagnostic purposes. Therapeutic purposes are spinal anesthesia to lower cerebrospinal fluid pressure if it is high, intrathecal antibiotics. And diagnostic purposes for meningitis, for encephalitis, for subarachnoid hemorrhage, to measure CSF pressure, and for Guillain-Barré syndrome. What are the contraindications? In unstable child, LP is not done. Reduced level of consciousness, platelets less than 50,000, increase in intracranial pressure, shock, and septicemia. What are the complications? Brainstem herniation can occur, bleeding due to thrombocytopenia, local trauma, meningitis, spinal cord injury, headache, and infection. Okay, what is hypothyroidism? There are types of hypothyroidism, that is primary hyperthyroidism, secondary hyperthyroidism, and tertiary hyperthyroidism. In primary hyperthyroidism, thyroid dysgenesis occur, defective thyroid hormone synthesis occur. Secondary hyperthyroidism is due to thyroid stimulating hormone deficiency. Tertiary hypothyroidism is due to thyroid stimulating hormone releasing hormone decrease. What are the clinical appearances? Prolonged physiological jaundice in neonates, lethargic, delay milestones, hoarse cry, poor feeding, large tongue, distended abdomen. What are the physical features? Hair is coarse, puffy eyes are present, broad nose and depressed nasal bridge, thick large protruding tongue, thyroid enlarged, bradycardia, cardiomegaly, constipation, short broad hands, cold and dry skin. These physical features will be present in the patient of hypothyroidism. What investigations are done? Low serum T4, serum TSH high in primary hypothyroidism while low in secondary and tertiary. X-ray epiphyseal dysgenesis and cardiomegaly. X-ray is done for these purposes: epiphyseal dysgenesis and cardiomegaly. ECG is done, echo is done. What are the treatment options? Replacement therapy with sodium L-thyroxine for life. Thyroxine is given a single dose orally in children, 4 microgram per kg per day. This is the dose. Thyroxine is given in the case of hypothyroidism in neonates. This is the asthma counseling. We will discuss it in another video.